Hello, welcome all to the session 5 of the Retrograde CTO Academy. In this session, I would be discussing about card technique of the Retrograde CTO. And in this case-based discussion, I would be discussing about the knuckle card. That means a knuckle of the retrograde wire is used to cause the card. That means initially what we were using a balloon, and nowadays we can use a knuckle made of the retrograde wire leading to the subintimal dissection, and that can help the antigrade wire to reach the crystal true lumen. So, coming on to the case in this, we would discuss about the diagram shown in figure C. In this, we can see this is control antigrade and retrograde tracking. That means antigrade wire is being tried to negotiate across this CTO segment into the distal tree lumen. And in this, a retrograde wire is taken across the septal or epicardial collateral that connects the distal true lumen. And once we are through the distal true lumen, we can take a small balloon that can lead to a subintimal dissection, and the wire from main lumen go to the subintimal, then it goes to the distal true lumen. This is how the process is done. And this is this diagrammatic representation which shows, suppose we have a LED CTO and the true lumen is seen here proximal to the CTO segment, and across this we try to negotiate the antigrade wire. And if it is not going into the CTO body and not going to the distal to lumen, then if we have a good interventionist collateral, then we can take the wire across over the microcatheter. We can try to cross the wire into the distal true lumen via good collaterals. And if it is not going into the true lumen, and then we can make a knuckle, a jug handle like appearance of the hydrophilic polymer jacketed wires like filter XTR. And sometimes we can, of course, use the wires like GA2, and we can also use the Gladius MG or Gladius Mongo. So, and we make a knuckle and we try to push it into the CTO body, and this will enhance or increase the subintimal dissection. And after this, we can try to negotiate this proximal wire, that is antigrade wire shown in the fluorescent color, into the subintimal space and can go into the distal true lumen. So from lumen to subintimal to lumen, this is how. And majority of the cases where we have a CTO which is calcified. So as per the ESC 2023 latest paper, which suggests that if you have got a calcified CTO segment and our balloons are not going or nothing is going, then and it is difficult to exteriorize the retrograde microcatheter, then of course we should use this knuckle cart. So coming on to the case, 60-year-old male, stable angina, ejection fraction normal. He already underwent a PCI to RCA, but already has a flush occluded from the ostia, and it was a failed antegrade attempt to the LAD. So JCTO score was 3, and the plan was to take the patient primary retrograde on this setting, and right radial JR4 was taken by 6 French guide catheter and right femoral access with EBU 7 French guide. So this is what the angiogram looked like. The LAD is blocked from the ostia. We can see we don't find any stump. So it's not good for antegrade. These are the cases I discussed in the session 1 and 2. The flush ostial lesions, CTOs, should be tried, can be tried as a primary this retrograde approach if we have a good interventional collateral. And this is how it looks like. And it is the stented RCA. We can see good CC2 collaterals coming from the distal RCA PD connecting the LAD. And we can see a diagonal branch also coming out at the distal end of the CTO. So again, it is for retrograde also, it's a bit difficult. And it is mainly epicranial and the ariocaudal view, or RA with cranial angulation, we can see. And in this RA caudal, we can see the connections the septals going on and connecting to the LAD. So these are the good intervention cholesterols we should try. So in this, we went with the Sion wire through mine cross microcatheter, but the problem with the this microcatheter fine cross, that trackability is an issue, and we were able to take the wire, but the microcatheter was not going into the septals. So plan was to negotiate. We tried to put this wire, although fortunately went into the LAD, and we tried to make an anchor in LAD by putting the this Xion wire into the distal area. But you can see a clear-cut angulation in the septal collateral. So there is a lot of angulation, and it is very difficult for the fine cross to go across these angulations. For this particular cases, we should change the microcatheter, and now the Corsair Pro was taken and a different septal was negotiated this time. And after a lot of efforts, we could negotiate this catheter as microcatheter as well as the wire into the LED. So this is how the micro was advanced, and now we try to negotiate the wire. We try to cross this distal segment with the Gaia 2. We thought that we can make uh, through inside the distal CTO to the body of CTO into the proximal segment. But we can clearly see from the ostia to the tip of this retrograde wire that it is a long segment. Although we tried to negotiate it, but it was going into a different plane. So, what is the next step? We also got a branch at the distal end of the CTO. So, we thought we can make a subintimal dissection with the retrograde wire because this segment is long and it has calcium. So, as shown in the figure 2, in between, we can see we made from access from RCA across septal collateral to the LAD. Now we make a knuckle, and from distal to lumen, this knuckle will go into the subintima, and it will lead to a subintimal dissection. And the antegrade wire we will try to negotiate to reach the subintimal space and then into the lumen. So this is how it was tried. And in various, after creating this section, we try to negotiate this filler, this wire into the distal lumen. So this is how a knuckle card looks like: calcified CTO segment, long segment, ostial flush occlusion. Then many times we would be successful. So antegrade wire was negotiated and it could reach the true lumen, and the wire was downgraded to run through wire. And this then the things were a bit difficult due to the calcified fibrocalcific segment, but ultimately with gradually sequentially dilating with the small balloons, we dilated this segment, and we implanted to the LM2 LED because there was a problem. Some initial first step, we came near the left main while we were negotiating the wire. So LM2 LED, this stents were implanted, and this was the end result. Good TME3 flow was obtained. So in this particular patient, we could see that it was a primary retrograde case because it has a ostial LED CTO with long segment and good interventional collaterals, as well as antegrade attempt was failed. So these are the primary indications to go retrograde primary approach. So many times when there is a non-crossability of the microcatheter, then of course knuckle cart is a viable option, because in the presence of setting of calcium, we would not be able to cross the this microcatheter from retrograde approach because there is a lot of calcium. So even a reverse card would not help because the calcium would not allow the retrograde microcatheter to go into the antegrade guide. So in this particular case, ostial CTO, no stump JCTO3 or more, needed a retrograde approach in the presence of good interventional collateral. So good hardware knowledge is also the key to perform the retrograde PCI. So this was about the knuckle card technique, and in the next session, we will discuss about the reverse card case. Thank you all for patient listening.